Hey, what up? What up? You guys can hear me?
So they need to go to some. They need the family needs to go where they can.
Okay, awesome. Yeah, thank you all for waiting. Good to see everyone. It looks like we're starting off strong. Yeah, how have you guys been?
Good. I passed my boards today, so it's been a big day for me.
Nice, congratulations. That's huge.
Thank you.
Yeah, that's a big deal. I remember I took my boards on my birthday, so like I definitely remember that feeling.
What did we congratulate her on?
She just graduated her boards, or she just passed them.
Oh, congratulations.
Yeah.
Congrats.
Yeah, that's a big deal.
Same for me was the DEA. Took a while.
The what?
The DEA.
Oh, like your DEA license?
Mm-hmm.
Oh, you just got that.
Not that I just got it. It took me a while to get it.
Oh, gotcha. Okay. Nice. Yeah, it does take a while. I remember I had to get my address verified too, and when I got mine in New York. So, okay, we're just having the recording software join, and then we shall get started. Oh, hold on, I just got kicked out. Give me 1 sec. Nice, good to see you, Aaron, Patricia. Hold on. Yeah, good to see you, Anne, Aaron, Patricia, Keisha. Welcome, and good to see you again, Joy. Yeah. Nice, Aaron. Where are you joining us from?
I'm from Maryland, from Baltimore, Maryland.
Oh, okay. Nice. Well, welcome.
Thank you.
Yeah. What kind of setting you practicing?
I work at University of Maryland School of Medicine. I work for the Department of Neurology. So I treat all their epilepsy patients.
Oh,
For
gotcha.
psychiatry, yeah.
Gotcha. So you have a lot of like neuropsych overlap.
Yes.
Yeah, that's huge. That's a big deal.
Yeah, it's tough, but I have a background. I do a lot of autism too, so I have a background in special education, which helps a lot. Doesn't help as much with the meds, but it helps with the just all the diagnosing and stuff like that. All the
Yeah, no, it helps with talking with the kids and stuff too.
yeah,
Yeah.
the medications, the nursing background helps with that, the psych nursing, but yeah, it's tough, but it's good.
Yeah. Well, good. No, I'm glad that you enjoy it. Okay, so let me connect share the screen. Okay, awesome, y'all. Can you guys see my screen? Okay, perfect. That's a yes, right? Yeah.
Yes.
Okay, awesome. All right, so why don't we get started here then? So, yeah, I think we had some good questions, especially this time around too. So what I was thinking we'd do is we can go through the people who are here, and then for the people who are not here, then we'll go through everyone else's too. So let's see. So Irene, are you with us, or Fatima? No, okay. So Lavita, you are here with us, right?
Yeah.
Okay, awesome. So Lavita was asking about amantadine, thought therapeutic effect of amantadine in kids. So this is so interesting. I remember the first time I saw amantadine, This was actually about 6 to 8 months ago, and we had a patient from Mexico who came into the clinic. And so this patient, they were autism, so they came in, they wanted to get a second opinion. Like family was in town for, like they were visiting America. And so the kid was on Amantadine. And so keep in mind, like I had already done my child and adolescent fellowship, and that was the first time that I had seen Amantadine. And so the family told me that he was on it for both autism and for ADHD. So I was like, oh, that's interesting because I had never seen it. And so, Levita, you're saying that you see the inpatient psychiatrists frequently prescribe it?
Yeah.
Okay, it's like what do you normally see? What doses or do you think it works?
Let me check, because I have a patient I was supposed to see today, and I could tell you what his dose is. He's 18. He just turned 18, but he's been on it for years. He is on 100 milligrams. It's loading. 100 milligrams twice a day.
Okay, gotcha. Yeah. So yeah, I was looking into it actually, and so I saw that there's some studies, and I'll upload it too. But yeah, there's evidence that it works for aggression. It's not like super strong evidence, but I think there's some new stuff that's coming out. Basically, with amantadine, it's one that now they're using for all sorts of different things. They're trying to see where else they can be used for. So it seems to be well tolerated. So I think that's nice. It seems to be working at least mild to moderately well. So I think I'm going to start including it in my own regimen now too, just as like more like a chronic option for aggression. And so I don't see anything wrong with using it. Like, what other thoughts did you have?
I was gonna say, I had an NP student that has been working at a hospital for a long time, and she told me for some reason the psychiatrist would put the kids on a break from Amantadine, and when they'd go on a break, you would see the difference, how aggressive they would get.
Oh, interesting.
I don't know why they would put them on a holiday from the Amantadine though.
Yeah.
That's what I wonder now. So I do have her number, so I will text her and see if she has an answer. Since she still works there. But I was thinking about using it for my difficult 7-year-old case, because I saw him for the follow-up, and it turns out not only did he have weight gain with quetiapine, but he has constipation too, where they have to give him a laxative every day.
I see.
So
Okay.
I had to keep reducing the quetiapine. So I went up on his Depakote to hopefully get him off quetiapine this last month of school, and then in the summer it'll be easier to work with and adjustments.
Got you. Okay, that makes
What's the
sense.
dose I'm sorry, what's the dose on the Amantadine?
The patient that I have that's currently on it, he's 18, so he's on 100 twice a day.
Yeah, and you
He's
can.
been on it for a while.
Yeah, and usually for adults you can go up to 400.
I've
Yeah.
been thinking about trying it too, because I've been hearing things about it. So I have adults, 16 and up, but I've been thinking about it for my aggressive patients.
Yeah, I have a kid. I'm thinking about it too. I'm actually seeing him tomorrow. He's a 10-year-old. Trauma history, autism. So real aggression. I tried clonidine with him. Apparently, it makes him sleepy. So I was considering switching him to risperidone tomorrow because he gets aggressive. They said that the mom gave me a call. She said that he flipped over a table and he almost injured their younger siblings. So like it's pretty bad, and he's bigger than his age too. So I was thinking of risperidone, but now I'm thinking, okay, maybe amantadine might be a more chronic choice too. Maybe I'll use risperidone PRN. But
yeah, less weight gain. I haven't heard of patients getting weight gain with it.
yeah.
For the CD.
So regarding it, I did a open evidence search, and then so here's what it said was so improve clinical improvement in aggressive behavior in children with adjunct amantadine, reductions in seclusions and PRN medications, associated with marked clinical improvement in impulsive and aggressive behavior. Double-blind placebo might include behavioral disturbances. So although parent-reported changes were not statistically significant, starting doses around 2.6 mg per kg to discharge doses averaging 6.7 milligrams per kilogram. So discharge dose is decently high. So imagine if you have a 70 kilogram person right? 6.7, roughly you might get to 400 milligrams per day. Appears to be well tolerated. So overall seems to be a good choice. Excuse me.
Awesome. We'll have to add it onto our list of medications, right?
Yes, that is in the works as well. So yeah, so that's Amantadine. Anything else on that? Okay. So then you mentioned about ADHD coaching without meds comparable to therapy as results in 10 to 30% improvement in symptoms. That's a good question. So my initial thought is that, stimulants we know are the number one thing for it. And the reason I think that is because, like, I'll give you another patient analogy. So I recently just saw this girl, 25-year-old patient with OCD. And so for her, she has tried exposure therapy, and she says she's literally not able to go through with all the exposures because of how distressing it is for her. So that's why she wanted to get the medication management piece done first, so that way she's able to go through therapy. I had another case, 20-year-old guy with Zoloft, OCD, same case. He always said he wasn't really able to do CBT. He has a lot of GAD too. He wasn't able to do CBT, deep breathing, until he got up to 150 milligrams of Zoloft. And once he got on that, he's like, wow, suddenly all the deep breathing that people tell me, it actually makes sense. Like, and he's like, the CBT exercises, like, I'm actually able to do now that I couldn't before. So I get a similar sense for ADHD coaching too, like for mild and moderate, like definitely, right? A lot of people might just need help with executive function, like, how to schedule, how to dopamine detox, how to do deep work, right? How to not get distracted, keep your phone away, focus on one task at a time, like that kind of stuff for ADHD coaching. Like I could see it definitely helping. But then when it gets to more severe levels, I think that's when the dysfunction just going to be so much that there's no way that the kid or the adult's going to be able to like sit down, follow through with it, and then actually execute on all the steps.
Yeah. I just find with ADHD, the parents, they generalize. They hear one case about one stimulant or one non-stimulant or both, and they don't want to do meds.
Mm-hmm. Yeah. What I tell them in that case is, what is the consequence of not treating ADHD? And I'll tell them another story where I remember I was talking to this patient, 25-year-old guy, and so he was saying that he got diagnosed with ADHD, but his mom didn't want him to get treatment, and so he never got treatment. I was talking to this patient in the prison setting. And so at first I thought that, okay, he just wants Adderall in the prison, right? It's classic. But then I kept hearing the same story over and over and over again. And so that really made me think, and like really I did a deep dive on ADHD after that. And what I realized was that with ADHD, it's a disorder of impulse control. And we know for teenagers, their frontal lobes aren't fully developed. So now let's say you have an impulsive teen who gets mixed in with the wrong crowd, the wrong influences, any kind of substances. Now they already have decreased impulse control, decreased frontal lobe function, and then you stack on ADHD on top of it. Their impulse control is like way lower. Their inhibition control is way lower. And so they're a lot more risk for crime. They're a lot more risk for poor school performance, leading to poor like college acceptance that can affect their job, their future. They're at risk for causing dysfunction with relationships and their friends, family. So I always tell parents, like, okay, so what about the costs of untreated ADHD? That is a significant risk too, not just the risk of stimulant medication.
Also anxiety and depression.
Yes, all that can...
Substance use, all of the above.
All the above, yeah. Untreated ADHD can lead to other comorbid psychiatric conditions like anxiety and depression.
Awesome, thank you.
Yeah. Anything else on that? Okay. Okay, now we have Diana. Diana, are you here with us? Okay, we'll pause. Patricia, are you here with us?
Yes, I'm here. Hello.
Okay, perfect, awesome. So this was quite the case you suggested here. So I'm glad that you're here because we can talk about it. So 80-year-old female, right? So locked memory care unit, visual hallucinations and paranoia. Brought in 6 weeks ago. Started getting lost. She left the house. Was calling police. Right. So definite paranoia, definite hallucinations and stuff. Living alone. Uh, so dementia, wandering around, Seroquel, worsened agitation, so poor insight and judgment, slum score is 11, so definitely a lot of dementia going on. Anything less than 20 is severe. So these are her current meds, so Risperdal, rivastigmine, trazodone, lorazepam. Collaborating psychiatrist fits like Alzheimer's more than with psychosis rather than Lewy Body, right? Recommended Risperdal increase, possibly adding low dose Depakote, lorazepam, right? Which we'll get to. Yeah, so walk me through this case. What are your thoughts? What are your experiences? And let's work through it.
Well, when she first came, she wasn't very confused. She's starting to get more confused as she's in the unit. So I wasn't sure if it's more she's just trying to adjust, or maybe it's the underlying dementia going on. I'm not really sure because I don't know what type of dementia she has. The POA has basically, she helps when she can, but she's got her own life, and the patient doesn't have any family, so she wasn't able to bring her to the neurologist yet. So we're still awaiting on that. So it's just more, I'm just trying to figure out if it's presenting more like a Lewy body, or if it's something with Alzheimer's with psychosis, because I know sometimes with the antipsychotics, it can make them more agitated. So is the Ativan making her more confused? The combination of medications. It's just, I'm just looking at it and I'm just like, I'm not sure which one could be causing what,
Exactly. So I think in this case, let's walk through each piece one by one so we can get clarity on it. So my first question would be, when I look through this history of visual hallucinations, paranoia, what is the dementia history? Did we start with the visual hallucinations and paranoia and then dementia started kicking in? Or was the dementia happening like years and years ago and now she's having the visual hallucinations? Like, do we understand her dementia course?
So her, the POA, the neighbor said that the hallucinations and the paranoia started first.
So she had no dementia before that?
No dementia before that.
So
she came in with no diagnosis.
Oh, okay. So see, that changes things, because if you're suspecting an Alzheimer's is usually a general, like it's a loss of memory, and then the memory ramps up over time, and then near late stage Alzheimer's is when the memory issue, the hallucinations and psychotic symptoms can start. But if this is just like she was fine and then all of a sudden got visual hallucinations, that's the understanding, right?
Yeah, that's what the POA was saying, that she started having paranoia and hallucinations for about a year ago, and it's just got worse.
Okay, so when I think about that, that makes me think, okay, is there something medical going on? That's what my mind first links to. And so, I understand that the labs were normal, right? Has there been any kind of infectious testing done?
Any type of what? I'm sorry.
Like blood cultures?
Yes, they did all that, like a full workup when she went to the hospital.
And that was all negative?
That was negative.
Okay, and then neurology, are they on board?
No, we're still waiting for a neurology consult.
I see, okay. So we're still waiting on neuro, right? So
yes.
Does she have any movement problems?
No.
So no Parkinson's symptoms?
No.
Because with Lewy body, generally you get the hallucinations and things first, and then the cognition stuff starts developing after. So I'm wondering if this is possibly a Lewy body, right? We talked about Seroquel and the antipsychotic sensitivity. And so the reason that happens is because if you think about Lewy body dementia, the Lewy bodies, they can integrate in some of the dopaminergic tracks, and they actually decrease that. And like that's why there's Parkinson's symptoms in Lewy body dementia, is because there is that destruction of that nigrostriatal path, right? And so that's what causes Parkinson's, the Parkinson-like symptoms. And so antipsychotics, especially high potency ones like risperidone, can worsen that because they're decreasing dopamine. Seroquel is less likely. Seroquel is one of the ones you're supposed to use for Parkinson's. Like you can use or Seroquel, pimavanserin. So you can use all that. So that makes me suspicious, right? Okay, so is this like a Lewy body? Is there something medical going on? This doesn't sound like a Alzheimer's. Like she doesn't, because also Lewy body also can have like a delirium-like symptoms where people they're that fluctuating attention, right? They'll recognize you, they'll know you, and then they'll suddenly forget, and then they'll know you. It's like the fluctuating attention, fluctuating memory kind of thing. So is that the case?
Right.
So I mean, so I think the suspicion should be a little bit higher from that. Plus, if there's any kind of something else that's medical, especially if the history tells us that it's not a gradual ramp up, but it's a sudden ramp up, then that is very suspicious. Even Lewy body is not supposed to be like a sudden ramp up of psychosis, right? And it makes me think about that one case I shared, I think last week. The guy was on anticholinergic med, or was on amitriptyline, and then he ended up getting hallucinations, took down the amitriptyline, and then he was fine. So, looking at this, this is all her meds? Like she's not on any other meds?
No other meds.
So she's pretty healthy then. Like
She is.
Yeah.
Yeah, she's on other meds. That's the thing too. She didn't go to the doctor for years and years. So I mean, but in general, like her other vital signs and blood pressure, everything's normal.
So what is going on with her family situation?
They're estranged.
I see.
So yeah.
So they have no info on her, no help, no family history, like nothing.
Nothing.
That's
She's a mystery.
That's very sad for her.
I know.
Yeah. So basically now what I'm wondering is, okay, is risperidone worsening her Lewy body dementia, right?
That's what I was wondering. Yeah. I was like, is it making it worse?
Assuming it's Lewy body, it could be something else too, right? I don't know if it's helping. Also, like this, like, do we really know if the Seroquel caused the agitation? The agitation could have been the underlying thing too, right?
That's true.
Right. That's like the history that other people give, especially non-medical people, because I assume this was like the POA who gave the history.
It was.
Right. They don't really know.
Right.
So that is worth considering too, because generally Seroquel is much better tolerated than risperidone. For that reason, Ativan, right? I know Ativan was discussed as well. So in regards to Ativan, right, the lorazepam, so that can cause disorientation, that can cause confusion, all of the above. Especially if she's 80. I mean, on the one hand, it sounds like before all this, she was doing cognitively well. So, I wonder if this case, who started all these meds?
Medical started the risperidone and trazodone.
I see.
And then I had started, because the thing was that she started refusing some medications to getting agitated. So that's why I tried the ABH gel.
I see.
Yeah, because that facility, they don't have a lot of the medications, like the IM medications for emergencies. So I have to kind of use what I can get,
Yeah. You got to work with what you got, right? That makes sense. And then the rivastigmine, did you start that, or did medical start that? Neuro?
I started that. That was the recommendation by my collaborating psychiatrist.
I see. Yeah, so that's good for dementia too. But that's assuming this is dementia. Like that's the confused. I'm also confused. Like, so she's been hallucinating for a year and just no one's done anything.
Yeah, that's the thing. She kept calling the cops, and and then finally she started getting lost when she would leave the house. So then that's why the neighbor stepped in.
I just feel like there's something going on. Like there's something that's the history's not complete. Like the picture doesn't make sense.
Right.
It's not like a gradual ramp up. the history.
Mhm.
She just started getting demented. I mean, so
Yeah.
the wandering is a clear clue. Okay, that
Mhm.
there's definite confusion, dissociation, or disorientation that's going on.
Right, yeah, and then the POA really couldn't give me much just because she's only, seeing what she sees, and really, she said that her hallucinations and paranoia started a year ago and just really started getting worse, probably, I wanna say, a couple months ago. They
Yeah,
started getting really bad,
I
to the point she was calling the police, like, every week or couple times a week.
see. Okay,
Mhm.
but it sounds like her memory's getting messed up too now. She doesn't recognize
It
you.
is, she's getting more confused,
Confusion,
definitely,
yeah.
from even
So this
even when I first saw her 6 weeks ago.
so this definitely sounds like more like a delirious kind of picture.
Mhm.
Right? Like it's like the fluctuating cognition with
Yeah.
the Lewy body dementia. Uh,
Mhm.
it makes me think, okay, what about like a prion disease or something
Mhm.
crazy like that? Some crazy neurodifferential. Like those are
Mhm.
autoimmune some condition that's going on,
Mhm.
right? Because she is not having Parkinson's syndrome. She's not having.
Mhm.
It's basically hallucinations that are leading to,
Mhm.
yeah. So
Yeah, this one's was complex for me, and so, then when
yeah,
I talked to my collaborating psychiatrist, he was like, "Well, you can try this," and it was just more like, "Okay, you can try this," but wasn't really telling me why, so.
absolutely,
Yeah.
absolutely, yeah. Uh, Rivastigmine, yeah, summer.
Oh, I might have missed this, but when did she start the risperidone?
She started the risperidone when she first got to the facility about 6 weeks ago.
Was that when the hallucinations got worse?
No, they're the same, but it's her agitation that's getting worse, and her confusion that's getting worse.
So everything's
Not
been
the-
getting worse despite the addition of medication, right?
Yes, yes.
Do you feel like the addition of medication has worsened the condition?
See, it's hard to tell because she knows she's in a locked unit and she wants to leave.
Yeah.
So,
Yeah.
it's hard because you can have a very linear conversation with her, most times. But then, when she starts to have the sundowning, she does get more confused. But she does know. I mean, sometimes she even says that, "Oh, some of these patients here, they're confused, and I can't talk to them."
Yeah.
So,
But could it be, with the risperidone, I think, right? Isn't that not, if it is, Lewy body thing? Like, is this where
It can
that
worsen it. Yeah. It
causes
can worsen it.
agitation and stuff like that? I'm
Yeah.
wondering if the.
yeah, I wasn't sure if what about maybe Abilify? Do you think that would be a little bit better tolerated for Lewy body?
Yeah. Seroquel, Abilify, clozapine. Those would probably be my go-tos. Just low dopaminergic binding.
Okay.
Yeah. Assuming that's the correct differential.
Right.
Right. I think that's the key here. Is there any way to get history before?
I really tried, the POA tried to contact family, they wouldn't talk to her, and, the patient, she says that she doesn't have any history, or, she's fine. When she first came in, she
Yeah.
was less confused. However, again, she never went to the doctor, so.
I see.
Mhm.
So we do what we can, right?
Yeah,
So it sounds if the primary problem is agitation, right?
it's more agitation, yeah.
Yeah, so
Right now.
Depakote might be a good choice as well too. Just be mindful of liver stuff. Lorazepam, I would just be careful on.
Okay.
You don't want her to fall. That would be not good because that could definitely happen. Sometimes patients can get paradoxically agitated as well from lorazepam.
Okay. Yeah, and the thing too is sometimes she will refuse medication, so maybe I'll do the Depakote, the liquid, hide it in something for her to drink, so.
Mm-hmm. Yeah, that's that's not a bad suggestion. Yeah, you can do that.
Okay, yeah, I'll try to do that. Yeah, I'm just waiting, and hopefully we'll get a neurology appointment soon, so. So
Exactly.
right now, I'm just really managing her behaviors, so. So
Yeah.
we can really find out, so. But other than that, like her vitals, everything else is stable.
Everything else is good, right? Yeah.
Everything else is good.
Yeah. So I wouldn't take all this case personally to you too. This is not a reflection of your abilities at all. This is a very tough case.
Okay.
But
So I
Trisha,
Yeah.
in the future, you can always reach out to me. I started in geriatrics and that's what I specialize in, and my family owns assisted living homes, so I'm very much around this all the time, so I'm happy to help, during the week or anytime.
Great, thank you. I know it's so geriatrics is so different, so.
It is.
Yeah.
Yeah.
Mhm.
It
I
require-
don't specialize in that anymore. It was a lot.
Yeah.
yeah.
Even when I was talking to my collaborating psychiatrist, he was like, well, you know, he was kind of unsure too. He's like, well, you could try this. So
Yeah. Exactly. We also have a geriatrician who joined us too. I am. So I'm curious what she has to say as well. I'll tag her in it.
Oh, nice. Yeah.
Yeah. So okay. Anything else on this case?
No, it's really just managing her behaviors because, you know, she's getting aggressive, resistant to care, and, you know, I can't have her hitting the staff and, you know, all that. So
Precisely. Yeah.
So,
So
yeah, I'll definitely, I was thinking about trying some Depakote for now and just really trying to push this POA to get this neuro consult. So, because
Exactly.
this memory care is like an assisted living almost. It's not like a skilled nursing facility. The POA has to take them. So, and it's more just having to push the POA to, you know, tell her, this patient needs the neuro consult. So,
Yeah, you're limited by the setting you're practicing in.
exactly.
Yeah.
Okay.
That
But I
makes-
appreciate it. Thank you.
Yeah, of course. I know it can be helpful just to talk it all out too. Get some
Mhm.
clarity that way.
Exactly.
Yeah. Okay, so yeah, we talked about this lean towards Alzheimer's, right? Yeah, the Emergency Drug Administration. Okay, so ARFID required labs to order. Yeah, so actually just finished up an ARFID lecture today too, so that'll be up soon. But basically the labs you want to order is all the nutritional stuff. So that's super important, like like CBC, CMP, phosphorus, magnesium, zinc, anything that can cause anything that's like nutritional. Basically, you want to order. Also, hormonal stuff is very key too, especially because if they're more teenagers, adults, if they have amenorrhea, they have anything hormonal going on, then you want to definitely check that out with ARFID, because ARFID can range from. I remember the youngest patient I had was a 12-year-old boy, and his family said that it started for him when he was 3. And when he was 3 years old, he was always picky, and it just got worse and worse. It never ever got better. So that's what they told me. But pretty much just your standard stuff. Nothing really that's too special or unique I can think of. If they have any kind of malnutrition going on, then maybe an EKG. EKG can be helpful. Make sure that there's nothing heart-wise going on. Make sure also that they're not developing into like a binge eating subtype, because then the ARFID could lead into other EDs as well too. So you want to be screening for that as well. Yeah, were you thinking of a specific patient or anything like that?
No, I was just thinking in general, because we've had a lot of questions and comments regarding like eating disorders.
Yeah.
So I know I've had some patients ask me about it, and I did see that you have to have the lab values. Because I know sometimes some patients might just have, let's say, more mood-based discrepancies in their eating, like you do with ASD, but you don't have the abnormal lab values where it shows the deficiency.
Yeah, the abnormal values aren't necessarily diagnostic. It's the behavior that's diagnostic, right? So if we look here, so this is for ARFID. I just need to upload this, but basically, yeah. So CBC, CMP, phosphorus, magnesium, TSH, vitamin D, all of this, and then inflammation stuff. So and nothing that really stands out that's like super unique for ARFID. It's more that the diagnosis is a clinical diagnosis. It's not a lab-based diagnosis.
Because there's an eating disorder center that I go to like once a month, and they have conferences. So I was asking about ARFID, And that's what they told me, that
What
it
lab
has
did they
to-
want?
Well, that it's usually like lab deficiencies. Like you have to have the lab deficiencies because, like, let's say you have eating disorder with like autism, but it's more mood based. It's not so much the nutritional deficiency that's present.
Yeah. Oh, I see what they're saying. So basically,
Mhm.
they're saying if there's a nutritional deficiency, that makes it more ARFID.
Yes.
And if it's not, then
Yes.
it's more like
It's more
autism.
mood based, mood and anxiety based.
I see. I don't think that's true because ARFID kids can, and adults, right? They don't have to have a mood disorder to have ARFID,
Mm-hmm.
right? And if it's autism based, then they would have other comorbid symptoms that would direct you towards that. ARFID is mainly the behavior of the eating disturbance, a lack of interest in eating, avoidance based on sensory characteristics. Here, let me put it up, right?
When they have ASD,
Yeah.
don't they have increased
First, yeah.
ARFID?
Pardon me?
When they have ASD, don't they have increased ARFID?
Yeah, they do. They certainly do. Yeah. But then ASD, ASD can have ARFID, but ARFID doesn't have to have ASD.
Yeah, I get that.
Yeah, exactly. So, yeah, I don't think there's any like specific lab value that says, okay, this makes it ARFID, or if they have a nutritional deficiency, they could,
Yeah.
But I think it just adds to the strength of your diagnosis if you can prove that there's a nutritional deficiency, for sure.
I just find that eating disorders are its own specialty.
It is. It's very tough.
And you need a whole team. That's why you have the eating recovery centers, because it's not just one provider and just talking to the parent. Like there's so much to it. Like there's cultural, you have to deal with the parent dynamics, or the parents going through divorce. There's so much.
So much, yeah. I just made my lectures over the weekend, so those will be coming up soon. But on them, I discuss my experience of working in an inpatient eating disorder unit, and that because basically the way that it works is that it goes inpatient, then there's a partial, and then they step down to an outpatient, and then they do family-based therapy during all of those phases, especially the partial and the outpatient. And then in the inpatient, they're very rigorous about what the kid's going to eat, what food they're getting, what calories they're getting. If they're not eating, they're monitored. If they throw stuff away, they are monitored. If they keep losing weight, then that tells you they're sneaking in stuff, and they might get an NG tube. Like I remember there's a girl in the unit, she would be sneaking away food. I don't know if to figure out how she did it. She also got a vape snuck in there too because she wanted to help reduce her appetite. So she had to get put on a NG tube because like her weight just kept going down. So it's a definite. It's not like an outpatient thing that we can treat. It's definite. It requires a village to treat an ED.
What are your thoughts? I know this is kind of related, but kind of off. Body dysmorphia and the patients wanting to get off meds, because I always tell them, hey, this is chronic. It's gonna come back. It's not. You're totally done with this issue.
Yeah. Is there any kind of specific body dysmorphia that you're thinking of?
I'd have to look up the patient's name, the one I have in mind. But what ended up happening is she didn't get off the meds. I kept educating her, and then she got her depressive episodes again. So we went back up and we maximized it. So I feel like she's kind of learned from experience.
Mm-hmm.
So we didn't have to totally go off the meds for her to realize, hey, this is something that's going to repeat itself and I got to be compliant.
Exactly. And that's the best way to learn is, right? And I think what's really important in that case is that the patient had the autonomy, right? So she wanted to come off, she made the decision. And so she learned from the consequences of that decision. And that's worth more than anything. Because if you had told her to do this, then she wouldn't have bought in. But now since it was her decision, now she is way more bought in.
Hey, thank you.
Yeah. Okay.
I will say one thing too. I have some experience with eating disorders, kind of outside of like formal, inpatient settings and stuff. And I've done a lot of learning and a lot of actually like coaching of parents, other parents who've had kids with eating disorders. And one thing is there's kind of like this misunderstanding out there too, that like if somebody has like body dysmorphia and they've had an eating disorder, that will always kind of be there to some extent. But one of the things that I've learned, and that I think is supported by some of the research out there, you know, kind of says that a lot of times when people have like ongoing body dysmorphia, it means that they just haven't gotten, especially with anorexia, that they just haven't gotten up to the weight yet that their brains really need to be at in order to be fully free of that. So just like a little bit of like personal sharing. My daughter had a very severe anorexia, like life-threatening. I had to send her out of state to ERC Dallas, which is like top in the nation, alongside like UCSD, you know, for younger children. And one of the things that we found with her was that she needed to be like a full 20 pounds above her prior growth curves in order to be completely well. But even at like, you know, 12, 15 pounds above prior growth curves, she still had body dysmorphia. But at 20 pounds, she had no symptoms whatsoever of eating disorder. And she's actually in like very sustained, solid recovery to this day with no signs, no symptoms, no thoughts. But a lot of people just don't get up to the weight that they really need, because we find, like, if you want to go down a rabbit hole at some point, look up the Minnesota starvation study. I won't go into all the details of it, but basically this was like a study that they did many decades ago. I forget when, it might have been like the 1960s or 70s. But they basically exposed healthy men to like a starvation diet, similar to what anorexic people do, like 1,300 calories a day. And then they kind of watched their behaviors, and it was very fascinating because they adopted all kinds of like bizarre behaviors that are common in anorexia just from the malnutrition. And then once they refed them and allowed them to eat again, they those folks, most of them went above their restriction weight in order to like nourish their brains enough to be well. And then they eventually like came out of all of their bizarre behaviors. But a lot of them like became chefs and bakers, and became really like obsessed with foods and really nitpicky with each other. And they developed all these like bizarre behaviors that are actually very commonly seen in anorexia. And that was the way their bodies actually came out of it, was by like overshooting their prior growth curves. So anyway, just kind of throwing that out there, that I think that's an area that I'm hoping in the eating disorder world that will kind of like catch up on more over time. But I think just because of like a lot of fat phobia and a lot of like understandable concern for obesity, you know, that a lot of our anorexic patients just aren't getting very good care in this area, where they really do need to be like above their prior curves to be well, like the vast majority of the time, including people who started off as obese.
Mm-hmm.
Okay, I'll stop. That's my little rant of the day.
No, and that makes complete sense too, because you think about it, all these mental illnesses, these symptoms are from the brain. Like the brain is a physical organ that produces them. So just like if the arteries, the heart gets filled up with plaque, if the kidneys don't receive enough fluid, they don't function properly. Same with the brain. If it doesn't receive its nutrients, it's not going to function properly. It's a machine. And then there's going to be errors in the machine. So all of those are literal signs that the brain literally isn't giving the energy and nutrition, the gas, the fuel that it needs to function. So that makes perfect sense to me. Yeah, thank you for sharing that.
Yeah, you're welcome.
Yeah, Michelle, are you here with us? Okay, or Daniel, or Christine, or Sarah, Kenita. Okay, then we'll just go from the top then. So we got Fatima, so she said drug-induced catatonia, what are treatment options? So I wonder what substance she's referring to, but regardless, like catatonia, you Ativan, like that's your go-to. You start with the Ativan, you do what's called an Ativan challenge. Basically, you hit them with 1 or 2 milligrams of Ativan. If you start noticing that they're getting better, if you notice any response, then that's diagnostic. And then you're like, okay, I need to hit them with more Ativan. And then you can do PO, IM, or IV. That's why Ativan's used. It's flexible. And then you just do that. I've seen patients get really better with Ativan. If they don't get better, like I remember I had this one kid, and so I talk about him in the catatonia lecture as well, but I had this one kid, and he presented to the ER, so he had autism and catatonia, and basically he had just stopped moving, and he was just sitting there, and I vividly remember him like raising his hand, and so he just raised his hand like this and left it in the air. And so as soon as I saw that, I'm like, okay, catatonia, like let's give him Ativan. So he got admitted to the inpatient psych unit, and so he was getting Ativan, just getting better, and then he would do these spells where he would stop, basically he would stop moving for a sec, for a little bit, and then he would just like run and sprint all across the unit, and then he would stop again, and then he would run and sprint across the unit. So he had what's called excited catatonia, and that's something that can happen too. Like you can flip between, like it's called the slower or the retarded catatonia, and then the excited, right? You can kind of go like back and forth between them. So, but regardless, Ativan was made a difference for him, just persistently over time. And then I had another case where the lady, she had schizophrenia, and then she had catatonia as well. She was getting LAIs, so we had to stop the LAI, and then did the Ativan. Ativan did not work for at least a week, so we went to ECT, and ECT is what made the big difference for her. So that's usually your top two go-to. There's other stuff that's been looked at, like Amantadine, for example, but the benzos, and especially the Ativan, and then the ECT, those are your top two. Yeah, anything else on catatonia? Okay, so Irene asks, I am a fairly new NP with minimal experience. How does one go about coming up with a plan while evaluating a patient? What resources should I use for prescribing? And would have a template I can use for the differential diagnosis? Yes, exactly. So I think, so what one thing you want to do is check out the classroom tab. So here, let me put that up here, right? So in the diagnostic assessment, so I go through pretty much every step. So interview overview, building rapport, HPI. So you really want to go through this because that way you understand what is in a full psychiatric interview. And so go through each of these, right? And then as you go through that, you have that skeleton in your head. And then what you want to do is you want to go through all the psychiatric disorders too, right? And the reason you want to go through that is because what you're trying to do in an interview is you're trying to formulate your differential diagnosis as you're talking with the patient. So patient comes in and you're trying to sort them into buckets, right? Are they filling into the depressed bucket? Is this the anxiety bucket? Is this an OCD bucket? Is this an ASD bucket? Is this personality disorder bucket? Like you're just kind of getting the vague generalities like when you're starting. And then when you hone in on it, right, there's like, yes, you start, okay, this is more anxiety, OCD, not really depression, right? Then you start focusing in on those, and then you start asking more deeper and deeper questions. So it's kind of like you're investigating. You start broad, and then you start going in deeper in your interview. So that's your goal with that, right? And so once you kind of establish the diagnosis, you do that in your head as you're going through the interview, right? Okay, so this is the anxiety bucket that we're dealing with. Oh, this seems like a GAD. Okay, this is not this is not a OCD case. Then the treatment algorithms in your head, right? So for example, right, so if I know if I'm doing GAD, right, so I would know in my head that, okay, if I'm trying to treat anxiety, I want to use a SSRI, right? That's what I'm going to start with, maybe an SNRI. Okay, let's say they tried some stuff. Okay, then maybe I want to go with Buspar, hydroxyzine, maybe I want to recommend CBT, maybe I want to recommend Lyrica, gabapentin. Maybe it's such a severe case that I need to go to a benzo, right? So this is where like really understanding the diagnostic criteria, understanding the treatment algorithms is what helps you understand the treatment for the patient. And this comes with time, right? It's not like once you become experienced, you can do it all in the one interview. But once you're building up experience, right, what we used to do as residents was we'd do the H&P, and then we would go present to the attending afterward and be like, okay, this is what I think is happening, and then this is what my plan is. But what that allowed us to do was like step out and research, like look up stuff. Like, so be looking up stuff. I'm like, oh, like what do I need to do? What do I need to prescribe to this patient? What should my treatment regimen be? And you can do that. You don't have to actually stay in the room with the patient the whole time. So you can always step out, take a break, research things, and then come back. So that's something that you can do as well too. Research. Any questions on that so far? Okay. And so for resources for prescribing, right? Hippocrates, great, up to date, great. You know, you can look in here too, all the, like if you look at every individual medication, right? You can look at all the different doses, right? So if I'm looking at anxiety meds, right? Let's say I'm thinking, oh, I want to do Prozac, for example. You know, you can look at Prozac and be like, okay, anxiety, right? So depression, OCD start at 20 milligrams per day, typical dose 20 to 60, max 80. Okay, so maybe I'll start at 10 to 20. Right, but then as you get as you get practice, you know the meds, like you start knowing them, and then you just know them in your head. But there's no shame in looking them up, right? Because that's how you learn it. And so something else that I used to do was if I had some history from the patient already, like they fill out their pre-charts or whatever, you can just look at that, and then you already have an idea of where you need to go because their pre-screening will say, hey, okay, I think the patient might have an anxiety disorder, or there might be a ADHD picture that I'm dealing with here. And then you can like have a general treatment idea in your head, and then you refine it through the patient interview. Does that make sense? Yeah, but this is a process that takes years, right? It's not a the psych interview is not an easy thing. Like it's an art, and it definitely you get better and better with it the more time you do it. And that's why there's a whole specialty for psychiatry, is because this is what we are supposed to do. This is our expertise. This is why we are separate from the others, because we can do this level of interview that other clinicians frankly can't, right? Because it's not their expertise, and it takes nuance and time to really develop how to do well. So there's no shame in that, and there's you just try to learn with every patient. Yeah, anything on that?
I wish to add a link. I added to the chat, and I went ahead and added to her comments. I think it's helpful to have a bone structure similar to how you explained. This PDF has just about most general diagnoses. Something I learned is it's always helpful to ask a patient what brings you in, and if that falls within that category, then now there's a guide to structure the interview.
Oh, this is great. Yeah. All right, I'm gonna upload this to the history docket, the tab. Awesome. Thank you for sharing that.
Of course.
Yeah, that's really good. Yeah. Yeah, because once you understand the structure, right? That's the key thing. You understand the structure of a history, and then you fill in the gaps as you need to. It's like the framework, right? Like when you have a house, you build the structure, the frame first, and then you fill in all the details. Yeah, anything else on this? Okay, so Diana says, any advice on med management approach patient with anxiety, depression, ADHD, PCP, Adderall, Xanax, duloxetine, no SI now, refilled Xanax, don't want to keep her on it, how do I wean her off, med recommendation? Yes, so this case, right? So my first question in this case is, okay, what is it that we want to accomplish? Like, what's the goal here? Because I think there's like the textbook answer, then there's like the real life answer. So the textbook answer is that, okay, she's on Adderall and Xanax, she shouldn't be on an upper and a downer, and so let's get her off the Xanax. Well, does she want to come off the Xanax? Because patients can really hold you hostage. With the Xanax, right? Because let's say she doesn't want to come off, and you saying that you want to wean her off, but she doesn't want to come off. If she doesn't want to come off, then yeah, it's like you're saying that she'll go elsewhere. If you don't prescribe it to her, and let's say she doesn't go elsewhere, then you are the last provider who had contact with her, and now let's say she goes into withdrawal, then now that's a bad situation because withdrawal can be lethal. And now let's say you do prescribe it to her, then now you're just stuck in this ever-stucking loop of prescribing her Xanax. So I think the key here is really coming up with those treatment goals, working with her to come up with the treatment goals. Like, what is it that the patient wants? Like, what is she trying to accomplish here? And then, so for example, let's say she says, I want long-term control my anxiety, then you're like, okay, well, maybe the Xanax is fine for now, but then long-term it might not be helpful. Or let's say she wants to avoid depression or dementia, then you're like, okay, well, Xanax, that might be something to come off of longer term, right? You use her motivation and her goals to help achieve the outcomes that you want to. But if she's saying I want Xanax, you're like, I don't want you on Xanax, then like you guys are gonna butt heads, and it's not gonna work out. What are you trying to target, right? Are we trying to target ADHD first? Like, is her Adderall dose too low? You suspect she has a mood disorder as well too. So I think that's the main thing that we need to do here is clarify what is it that we want to accomplish. What's the goal that we want? Are we trying to target anxiety, depression, duloxetine, for example? So she's saying it's not working, right? I mean, 60 milligrams is a good dose. So yeah, you can go higher to 90 or 120 per day. But if she says it's totally not working, you could cross taper it to another SNRI. You could do an SSRI as well. If there's any kind of mood lability, irritability, if you suspect bipolarity, right, Abilify can certainly help as well too. There's some treatment it can help with depression treatment as well as an adjunct. But I would be inclined if the I like to use adjuncts if I notice that the primary agent has had some benefit. So, she says duloxetine is not working, doesn't mean, okay, so she says she feels no effect. So that makes me think that, okay, maybe it's time to switch it because the primary treatment's not having any effect either. So those are just my thoughts in reading this. But I think that we need to make sure that that we establish a goal and like we're working towards that goal as opposed to just kind of making changes based off just seeing a med regimen alone. Does that make sense? Yeah, and any thoughts on that? Yeah, exactly. So screening for, yeah, of course. Go ahead.
Hi, doctor. My name is Princess.
Hey.
New here. But my question is, how do you feel about like treatment agreements prior to starting any benzo or any stimulant medications?
Yeah. So I remember when I was in my residency, we had discussed doing that. And the consensus we came to, and like especially with like we're gonna do UDSs and all of that, and the consensus we came to is that people are not gonna follow through with it, and we'll lose half our patient population. So we decided as a clinic, the clinic administrator decided not to implement that policy. What do you mean by an agreement exactly? Is it like you're going to stick with X amount of benzos and stuff per month and we're not going to change?
I usually have my patients sign this agreement that I can drug test them at any time when I request for it. They only come for like in-person appointments. I work in a community health center, so that's the nature of the population that I usually see. And of course, we're trying to avoid benzos as much as we can because we do see a lot of SUD patients as well.
Right.
So most of the clients who goes to us usually know that my goal is to taper them off the benzo. And usually those who are willing to try it, stick around, and then they, like what you said, they kind of fall off when we're towards like the end of the taper.
I see. Yeah, so that's another very key point. The population makes a huge difference. So I did some community mental health work there as well, and there we had a similar thing where we were a lot more limiting. But then I've also worked in a concierge private practice as well, and there that would be very frowned upon to have an agreement like that because it would betray. It almost seems like you're accusing the patient, right? So I think it really just depends on the setting. But I do think if you have that, especially in the CMH system, it gives some level of legitimacy to it. It's like, okay, like we don't play around, like we take it more seriously.
Makes sense, doctor. Thank you.
What do you think about it? Do you like it? Do you find it strengthens your alliance with the patient, or do you find it causes a gap between you guys?
I feel like it does help. It really does help because it encourages the patient to seek for like therapy. I make sure that I follow up with them, that they talk to somebody, getting to therapy while we start on like SSRIs, any other anxiolytics that are non-benzodiazepine, while we taper them off the medication. But then I just had this client who was like, I felt for him. He was like a 60-year-old man, tested positive on cocaine when I caught him. So, and he called the insurance, and he was saying that I was accusing him of using drugs because he said that he doesn't do drugs. He only drinks coffee. So he requested for a new provider. And it was an easier, termination on my end because he was the one who requested to go. So I just don't know how you feel about that, ethically speaking,
I'm a huge believer in patient autonomy. I value that almost above everything else. So if whatever the patient wants to do, if they want to terminate with me or anyone else, then I'm not going to fight them on it.
100%, doctor. I'll be more than happy to assist them with resources. Thank you. I have a list. I already have a list of resources. Here you go. Thanks for everything. Take care of yourself. That's all I say.
Exactly. I think, you have to, if you want kids to grow up, you have to treat them like grown-ups, right? You don't treat them like kids. Similarly with patients, the standard that you hold them to is the standard that they have to rise to. And if you hold them to a low standard, then that's what they're going to meet. So you hold them to a high bar. If they don't want to meet it, then, that's their choice. Every person in life, makes a choice. And all our goal is that we're just guides on their journey to help them with the decisions that they want to make. Yeah. Anything else on that? Okay. So yeah, Patricia went through her stuff. Okay, Michelle says clients waking up 3 to 5 a.m., no change in caffeine, sleep apnea. Then cortisol levels and sleep hygiene, anything else I can look to try to help with that? Yeah, so I would look at, any kind of comorbid psych condition, right? Is this from anxiety? Is this from depression? Is this, no sleep apnea? Is there any kind of other sleep disorder going on? Is it just that they're doom scrolling? Is it that they're taking any sleep supplements? Like for example, melatonin is notorious for causing this kind of wake up, especially because patients develop a tolerance to it, and then they start waking up throughout the night because their body's not secreting the natural melatonin anymore to keep them asleep. It's because it's so dependent on the exogenous melatonin that we give it. And that melatonin, especially if it's not a controlled release, it's more of an individual, like it's usually the over-the-counter ones are the IRs, and so they tend to wear off. So I would look at just like any other kind of comorbid psych condition. The easiest way to treat it is you can use magnesium glycinate, you could use L-theanine. Those would be the top thing. You could use melatonin CR if you want to on some nights. But I think a lot of that would probably be the sleep hygiene, honestly. Most patients in general just have very poor sleep hygiene, much poorer than they believe they have. Like they don't realize that, oh yeah, I'm using my phone till late at night, or I'm eating food up till before I go to bedtime, or I sleep with the TV on, like stuff like that. I drink caffeine. That's a huge one. No change in caffeine, right? What if they try to reduce the caffeine? That could be a thing as well. And yeah, I would definitely look at labs too. Labs can be helpful. Make sure that you're not missing anything. Medication changes. Yeah, it's hard to say just on this because sleep is almost like a symptom. It is a symptom. Disruptive sleep is a symptom of so much else that's going on. Okay, and then we see here different clients, constant complaints of fatigue and low motivation. These are constant complaints. Yeah, I think that's just the nature of our business, right? This is the bread and butter of our business is fatigue, low motivation. Honestly, I think a big component of this that no one talks about is phones and dopamine. Basically, the way it works is that when people are addicted to their phones and scrolling all the time, which 99% of people are, then it raises the threshold of dopamine. And so now because they're getting free dopamine. So because they're getting all this free dopamine, normal things don't give them the same level of pleasure, level of motivation, anything like that anymore, because they've raised their dopamine threshold here. Like, it's way more fun to scroll on your phone and get free dopamine than it is to do anything productive and be motivated. Like, that's something I've noticed just now in myself when I've right now, as I'm working on this business, for example, right? I noticed that if I even watch one episode of TV, I don't want to do anything productive anymore, because the pleasure I get from the TV is way more than the pleasure I get from working on like this program and everything and all this, because this gives me X amount of dopamine, TV gives me way more dopamine. So I have to subject it to the end of the day. Otherwise, I've already raised my dopamine threshold, and it's way harder to motivate myself to do something after I've already got all that dopamine in. So I think that's a huge cause that nobody ever talks about, but it's getting a lot of popularity nowadays online, the dopamine detox. But other than that, right, if we're talking just general lifestyle, making sure that people are sleeping, making sure it's 8 to 9 hours, making sure that they're eating healthy diets, not processed foods, because processed foods will mess all of this up, making sure there's no nutritional deficiencies. If you want pharmacologic, right, these two things, Wellbutrin, modafinil, like those would be the top two. I would think of maybe Prozac's more stimulating as well. If you want supplements, omega-3s, awesome. See you, Richard. Omega-3s, you could do green tea extract. SAMe is a stimulating supplement too. I think of it like a supplement version of vitamin or Wellbutrin. If you're trying to find low motivation, right, you have to find a reason to be motivated. The analogy that I use with patients is that imagine somebody tells you that you have to get in a car and you have to drive. You're going to be like, why do I have to drive? Because you don't have no motivation to drive. Now, if I tell you, hey, go drive because we don't have gas or we don't have food in the home. Oh, so see, now suddenly you got motivation because now you know that there's no food in the home. So, but now you're going to be like, okay, where do I drive to? There's no food in the home. Like, the grocery store down the road. Oh, okay. You drive there. So you need to improve motivation, to have purpose in your life, you need destination and you need a reason to get there. Just like, when you get in your car, we need the grocery store, the destination, and we need a reason to go there, which we have no food in the house. So I think a lot of people, like, they are feeling lost and confused, and because they don't either have a reason to do something or they don't have the a goal that they're trying to accomplish, like somewhere that they want to go. So I think journaling, figuring out all of that is super important to really help their lives, and that's more of a holistic thing. Any thoughts on that? Kind of went on a soapbox for a bit. Okay. So Daniel says, if a patient's anxiety is not being well controlled after adding Buspar and an SSRI, what would be the next step in management? Would adding hydroxyzine be appropriate? What about Wellbutrin? Yeah, so my question here would be, okay, what doses are we talking about? Because this is so important. I always run into this where patients get on meds, but they're not on the right doses. And if they're not on the right doses, then it's kind of pointless. So I don't know what dose Buspar we're talking, right? I don't know what dose SSRI we're talking. So this is definitely important to acknowledge. Even knowing their metabolic status or how they metabolize stuff, right? So let's say if they're a fast metabolizer, even if they might be on like decent doses, then because they're a fast, rapid metabolizer, that may actually be lowering their dose. So that's something I would definitely check out. If we're trying to do more lifestyle, holistic things, right? Are they doing CBT? Are they doing any kind of therapy exercises? That's what I would want to wonder. Are they doing any kind of meditation? Supplement-wise, are they doing, let's see, magnesium glycinate, L-theanine, ashwagandha? Those are some supplements that they could take for anxiety, right? Are they sleeping well? Are they eating a nice, clean, whole foods diet, or is their diet full of processed foods? If they have a high sugar diet, then their anxiety is going to go all over the place because, their sugar goes up, their sugar goes down. So now their energy levels go all over the place. Sometimes if the insulin overcorrects, that fall can cause hypoglycemia, and that hypoglycemia can mimic anxiety levels. So yeah, I think there's a lot to definitely assess there. Would adding hydroxyzine be appropriate? Yeah, you can. Hydroxyzine is better usually as a PRN. I've had some patients take it scheduled, so not saying you can't do it, but usually it's better as a PRN. So you can certainly do that. Wellbutrin can certainly be activating and cause anxiety, so I'd only add in Wellbutrin if I'm trying to target mood or low energy or ADHD, and the anxiety is stable. And you want to make sure that there's no medical causes here too for anxiety, like nutritional, thyroid, deficiencies, diabetes, infectious, all of that stuff. Anything else on this? Okay, so Christine says, I see geriatric patients with schizophrenia now in nursing homes. At what point do you start to wean off antipsychotics, if ever? Which ones would you change as patients age? For instance, still have a few on Clozaril. So that's a good question. So generally the rule is you want to have people on about 6 to 12 months of, when their symptoms are controlled. And that's when you start to taper off of stuff. So, in these nursing homes, right? So if they have schizophrenia, it sounds like it's probably long-standing schizophrenia. So you could definitely try to wean them off of it. Just make sure that you do it slowly. And that's why, because you want to assess them, right? You want to make sure that they don't start regressing with schizophrenia. Or, as we saw in the other case, right? They could be having some dementia or something on top of that. And they could be having sundowning symptoms, some psychosis that comes from that. So you just want to monitor for any symptoms that come out. Just taper them off very slowly. I don't really have a specific point or age. I'm always, with every medication, we're always trying to weigh out, do the pros of me using this outweigh the cons? Like, that's it. And if the pros outweigh the cons, then you use it. If they don't, then you don't. Like, it's simple as that, right? For example, Clozaril is very anticholinergic, so that makes me hesitant, especially in the nursing home population, because the anticholinergic can cause, worsening psychosis, hallucinations. So maybe it might be worth transitioning them to something that's less anticholinergic. For example, like risperidone, Abilify. Seroquel is well tolerated as well too. So that would be my thoughts on that. Anything else on this? Okay, so then Sarah says, I have a tough but wonderful 32-year-old patient, treatment-resistant depression, ECT, so did Auvelity, all of this, ketamine, failed medication trials, bipolar 2, some possible elevation, hypomania type of symptoms, right? Deep, desperate depression. Tried ECT, but having memory loss, lithium, nortriptyline. Yeah, so basically now she's on lithium, she's on nortriptyline. So it sounds like a ECT, but she's having memory issues. So yeah, it sounds like a tough case for sure. Would there be a benefit to switch her to ER lithium at this point, if she's using therapeutic levels? She's been told she's a fast metabolizer in the past. So lithium ER and IR actually have pretty similar half-lives. Like I remember I had an attending in my residency or my fellowship who actually would prescribe IR lithium because he's like, well, they have the same half-life. It's just that the IR lithium peaks quicker than the ER, and that's true. So I don't think the ER would make that much of a difference in terms of that, but I'm wondering, like, you could just increase the dose, right? So if she's on 900, you could certainly increase it. 900 is a decent starting dose. Like I remember this attending, he would start him off at 900 and then get a baseline and then go up and down from there. So you could certainly go up to like 1200 or 1500. I do agree with you, especially when I see this kind of deep treatment-resistant depression. That makes me think of bipolar, especially if she has these periods of elevation, mood, energy. Um, and that's what makes me wonder is that why isn't she be trying on an atypical antipsychotic, right? So if you wonder about bipolar 2, there's no history of any atypicals. Like there's an ECT that's going around, but she's never tried Latuda, Abilify, uh, Prozac, fluoxetine, Caplyta. So that would be my thought. Like, okay, so if she's still resistant, why not introduce some of those to really target the depression rather than the ECT? TMS could be also be considered too, right? So if she's trying the ECT, she's clearly having memory problems, memory and functional impairment with this ECT. Then why not do something like TMS rather than doing this ECT, which is clearly causing a lot of harm to her? Yeah, I have thoughts against that. So combat daytime sedation brought on by nortriptyline. Morning sedation keeps her. So maybe we could reduce the dose a bit of the nortriptyline. So you could do either that. I also had another patient who had the same thing with amitriptyline. At bedtime, he'd had the morning grogginess, but he started taking it at 6 p.m. And then he noticed that when he took it then the morning grogginess was gone. So that could be something to try. You could try moving it earlier, like have her take it a little bit earlier, or just try reducing the dose, right? Because as I said, like meds are all about trying to weigh out pros and cons, and so here it seems like the cons are definitely high. So if by reducing the dose, we might reduce the benefit a little bit, but if we can reduce the cons significantly, then now the benefits outweigh the cons. So yeah, those would be my thoughts. Consider antipsychotic, atypical for bipolar depression. Lamictal as well. Like I don't see a mention of Lamictal here. That could be done too. Yeah, consider lowering nortriptyline or moving it earlier. I don't think the lithium is going to make much of a difference here. Switching it to ER, but you can definitely increase the dose as well to get to a higher level than where you were at. I think it was 0.5 that I read. Yeah, 0.5. Yeah, any thoughts on that case?
I had the same thought about TMS. I'm kind of surprised that they would jump to ECT before TMS, just some of the data that we're seeing on that. But I also noticed that they're doing, it said like something about occasional IM ketamine. I mean, that wouldn't really be enough. It could be like full efficacy with that medication. And some folks like need a lot higher dosing and more frequency than others.
Yes.
And I'm hearing that there's like some pretty good data, or at least like, you know, they're starting to look at ketamine more for bipolar depression, whereas, you know, in the past it was just more for unipolar. And, you know, I wonder if they were able to like optimize the ketamine dosing, if that might be helpful as well.
Yeah, that's another point as well too. Yeah, really optimize the ketamine. You get quick. Oh, and then another thing with that is that I wonder how stacking these two is going to be, right? Because ketamine already causes some dissociation, and then now we stack it with ECT, and it's like, are we dissociating, confusing her, messing up her memory too much here? So that's another thought that I have regarding that. Yeah, maybe she needs to do Spravato. Yeah, but my first thought would be, okay, why isn't there no atypical antipsychotic or Lamictal on board? Right, like starting from like less interventional, less extreme to more extreme stuff. Yeah, anything else? Okay, so Kanita says, thoughts on the utilization of multiple antipsychotics at the same time? Oral plus LAI, 2 different LAIs, first gen versus second gen, patients are in active severe mental illness. Yeah, so we do this a lot in the prison population, and I've seen it with some patients in the ACT care team as well too. So basically, some people just have treatment-resistant conditions. So what you want to do is you want to get the first antipsychotic optimized, and then switch over to add on the second as you need to. So usually, for example, the way it works in the prison is someone might be optimized, let's say, on bipolar or olanzapine or risperidone, usually olanzapine, And then they might add on, for example, Haldol or Prolixin or Thorazine adjunct. So that's how they would do it, right? And then the way that you would stack that is use something that's higher potency and then use something that's lower potency. You don't want to combine two high potencies as well, because then you're just going to shoot your risk of EPS through the roof. So for example, let's say that the second gen they're on is Seroquel or quetiapine, or let's say maybe even olanzapine is like it's kind of low potency, kind of high, but Seroquel is low potency. Then you could stack it with, for example, Haldol, which is high potency. Or if you have risperidone as your second gen, then you could stack that with chlorpromazine or Thorazine, which is more of a lower potency, right? Because it's got a higher dosage range. So that's how I think about it. But yeah, I always try to max out one before you add in the second one. Yeah, and then you can definitely do that, right? Oral plus LAI. 2 different LAIs is definitely a lot, but it's the same concept, right? Some people just need some people are just more severe that they need that. And then usually with an oral plus LAI, you have to do an oral overlap to get them on an LAI as well. Or like, if they're already on an LAI, then they might need a little bit more coverage and you've already maxed out the LAI. So that's when you have to add in something else. And that's why you see the oral and LAI. But it's not ideal, but it does happen. But then I would also ask, okay, could clozapine be used here, right? If they're that severe, has that ever been considered? But then, I see you say they're not very compliant with oral medication. So this is probably not the best population for either clozapine, if they're not really compliant, or maybe for oral too. So possible co-occurring substance use. Yeah, that's a thing too, right? So if a lot of them are smokers, then smoking decreases the levels of olanzapine, clozapine. So that can be impacting why they're on 2 antipsychotics. So a lot of different factors here. And this is the ACT population. This is just a tough population overall. So this is unusual, but not unheard of. Yeah. Anything else on this? Okay. Anything else that anyone else had we did not cover? Okay, awesome. Anyone want to share anything off recording? I'll stop the recording now. So I'm glad that everyone, so if you're listening to this, I'm glad you stayed here. And I think we had a lot of good gems today, a lot of good stuff. So, okay, let me end this. Let me add this one and this one too. Okay, recording has been stopped. So awesome. Yeah, anyone want to say anything off recording, anything to get off your chest?